In our next chapter, we are going to discuss drugs for pain management. And pain is something that everybody in nursing school should be familiar with. So here we see Dwight Schrute saying you need to read and take notes. So hopefully you're all still doing that. So we're going to talk about medications for managing pain and also discuss some anesthesia at the end. So once again, not a super long chapter, 14 pages, pages 210 to 224 in your textbook, and in your ATI book, various pain medication issues and medications are discussed in chapters 30 through 33, and they're not real long either. So we're going to talk about narcotics. This chapter deals with narcotics and drugs that are needed for moderate to severe pain. In chapter 12, our last chapter, we'll be talking about skeletal issues and things that we need pain medicines for in a different area. But this is going to talk about mostly drugs for moderate to severe pain. All right, so we're going to primarily be talking about opioids. And when we say opioid, we kind of use opioid and narcotic interchangeably. They're basically the same thing. All opioids are narcotics, but not all narcotics are opioids. But there are two sources of opioids, or two kinds of opioids that we study, but all natural opioids come from opium. They come from the seeds of a particular poppy plant, and there are poppy plants all over the place, but the one we're talking about are opium poppies. They're not just to look pretty. They have seeds that you can process, and you end up with morphine and codeine, two byproducts of natural opium. Through the years, as we have studied the chemical composition of natural opium, and we have, our scientists have developed new medications, we have come up with synthetic forms of opium. So we've got heroin, which is semi-synthetic, and it's going to eventually break down in the body into morphine. But then we have a lot of synthetic pain meds that I'm sure you recognize. We've got hydrocodone and oxycodone, and then hydromorphone. All of these are man-made. So the action of the opioids is to interact with opioid receptors in the brain and spinal cord. And they're intended for moderate to severe pain. Now, our body contains 6 types of opioid receptors, and they all have different side or adverse effects. Now, the therapeutic effect of opioids is to reduce pain, and there are receptors that will give you analgesic effects, but then there are also receptors that can cause different side and adverse effects, some of them pleasant, some of them not so pleasant. So on pages 214 to 215, we talk about the main opioid receptors, which basically just sounds like a row of fraternity buildings. We've got mu, kappa, delta, epsilon, and sigma. Now, all the opioid meds that we're going to take, or that we're going to be talking about, that act on receptors, act either as agonists, as partial agonists, or as agonist antagonists. And there's a particular type of medication that we'll be talking about that both activates opioid receptors and blocks other opioid receptors. So if we go back in the deep reaches of history, we remember when we talked about these various definitions in chapter 4, So as we remember, an agonist is a chemical that binds with certain receptors to activate and produce the maximum response of that individual receptor. So an opioid agonist is going to bind with that receptor, and it's going to produce the therapeutic effect of analgesia or pain relief, and it's also going to produce side effects like drowsiness, dizziness, possibly euphoria. Also can maybe produce some unpleasant side effects like itching and nausea. And they all vary depending on the different types of individual receptors each person has. We have drugs that will act as a partial agonist to produce a partial response. We talked about drugs that are considered antidiarrheals, that have a mild opioid along with usually atropine. So something like Lomotil, it has a very, very mild opioid effect. So that's going to produce a partial response in a person who takes it. And they might get a very mild buzz from that opioid, but it's not going to be a really strong opioid in its original form. That's just one example. Then we've got agonist-antagonists that I just mentioned in the previous slide, and they act as an agonist at one type of receptor, and they will compete as an antagonist with another type of receptor. So when you've got a drug that's considered an agonist-antagonist, you don't get the full opioid effects that you would with just a pure opioid. So let's talk about some common opioids. We've got table 11.3 on page 215, and this just discusses some of the common opioids that we're going to run into. Our prototype opioid is going to be morphine. Morphine has been around for a long, long time, and it's the drug of choice for certain conditions. For instance, MI. If you come in with symptoms of a heart attack, they're going to give you morphine unless there's some reason you can't take it, because morphine both alleviates pain and vasodilates to cut down on the oxygen requirements of the heart. It makes things a little bit easier for the heart. It doesn't have to work so hard to pump oxygenated blood. Morphine is often used in the acute care setting for post-surgical pain, for acute pain that you might get with an injury. You know, you fall and break your leg. They might give you morphine to alleviate it. And it's a very commonly used drug in hospice. In fact, they will many times bring an oral form of morphine for you to give your loved one, and it just goes directly into their cheek or under their tongue. One form of morphine is a drug called Duramorph. It's a synthetic morphine, and it's often used after surgery and after C-section delivery. It can be given IV or it can be given in the epidural. If it is given in the epidural space, it activates certain receptors that cause itching. So it's not that a person would be allergic to Duramorph, it's just that it activates the itch receptors, and you see that almost universally with moms who have C-sections and get a shot of Duramorph after the C-section. It gives good pain relief for about 24 hours, but it's going to make her itch like crazy. If Duramorph is given post-surgically, for pain relief, and it's given IV, it has to be given very, very slowly over a period of about 4 to 5 minutes. We talked about codeine, which is a natural opioid, and hydrocodone and oxycodone, which are synthetic opioids. These are given PO, usually at the doctor's office or in a clinical setting, and they can be given in prescription form for the patient to take at home. Hydromorphone, otherwise known as Dilaudid. It's a a very popular drug. People ask for it by name, but it is commonly used in the clinical setting because it minimizes a lot of the common side effects. It gives good pain relief without giving some of the more unpleasant side effects. It's used for severe pain that morphine hasn't touched. It's considered to be 7 to 10 times the analgesic effect of morphine, so it's a lot stronger. For instance, you'll see sometimes a person with pancreatitis, which has severe discomfort. Sometimes they'll be on a dilaudid PCA because you can give less dilaudid and they get a greater pain relief. And then with fentanyl, fentanyl has gotten a lot of notoriety because it's produced illegally and cut into certain kinds of drugs. Very, very dangerous. But it's given in a clinical setting, many times in a patch. It can be given with an epidural in the epidural space, very effective pain relief, and it can be given as a fentanyl patch for people who have severe chronic pain. You put this patch on, give it every 72 hours, and then take it off, clean the skin, and apply the patch in another area. And of course, you want to make sure that your patient's on a pulse ox while they have a fentanyl patch, and instruct them not to fiddle with that patch, not to pick at it, not to let anyone else play with it. When I was working in case management, we had 2 patients who were transferred to a rehab floor, and both at separate times decided that chewing on their patch would be a good thing to do to get a stronger effect. Both of these patients had to be coded. One patient was able to be brought back, the other one wasn't. So you just don't want to fool around with fentanyl.